Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show.
My name is Dr. Don Stater. I'm an emergency and addiction medicine physician and the medical director of the Compass Opioid Stewardship Program. This week's case is about Edward, who is a 45-year-old male patient experiencing chronic abdominal pain for over 5 years. The patient has had multiple CT scans, endoscopies, and other procedures without clear etiology of pain. His GI doctor has diagnosed him with irritable bowel syndrome and daily chronic abdominal migraines. The patient has tried multiple medications and is currently on a fentanyl patch and oxycodone for breakthrough pain. On exam, Edward has tenderness to palpation out of proportion and complains of poor function and pain management. He also complains of significant anxiety and depression due to his pain. In today's microlearning, we're going to discuss the concept of nociplastic pain, how to make the diagnosis, and how treatment of nociplastic pain differs from other types of pain management. First, let's start with some definitions. The International Association for the Study of Pain, known as the IASP, defines 3 major categories of pain: nociceptive, neuropathic, and nociplastic. Nociceptive pain is caused by tissue inflammation and damage. Neuropathic pain is caused by nerve damage. And nociplastic pain is a third category of pain that is caused by errors in sensory processing and altered pain modulation. Nociplastic pain includes multifocal pain that is more widespread or intense than expected given the amount of identifiable tissue or nerve damage. Oftentimes, patients with nociplastic pain have normal diagnostic studies, as well as other CNS-derived symptoms such as anxiety and depression. The classic example of nociplastic pain is fibromyalgia. A patient like Edward is highly suspicious for nociplastic pain, and the treatments Edwards is currently taking may be suboptimal to accomplish his pain goals. The diagnosis of nociplastic pain is often a clinical diagnosis and made after diagnostic studies have ruled out other common causes of nociceptive pain. In his example, possibly Crohn's disease or ulcerative colitis. The Central Sensitization Inventory is another tool. It's a 25-question validated questionnaire that can also be helpful in identifying patients with nociplastic pain. One final definition or term that clinicians may hear is that of neuroplastic pain. And this is a non-IASP term, but can be considered a synonym for nociplastic pain. It is often associated with practitioners of mind-body medicine and integrated with the thought that much of nociplastic pain or central pain is learned by the central nervous system and hence can be unlearned or addressed through learning. It is essential to diagnose patients like Edward with the correct pain type, as it significantly influences the treatment that should be and can be pursued. For instance, it is known that nociplastic pain often worsens with opioids. Opioids often result in poor pain control, decreased function, and worse long-term outcomes for patients with nociplastic pain. Treatments that have been shown to be more effective for nociplastic pain include mind-body interventions, cognitive behavioral therapy, enhanced understanding, self-management, sleep hygiene, graduated movement, and when it comes to pharmacotherapy, medications such as duloxetine, tricyclic antidepressants, or low-dose naltrexone. So let's get back to our case. When I see patients like Edward, I like to assess how much he may have been educated on his pain and his pain type. I often ask if he's ever been educated on the difference between nociception, pain, and suffering, and evaluate if he knows the difference between nociceptive and nociplastic pain. I often address items such as pain anxiety and emphasize the non-pharmacologic aspects that can improve patients' pain and overall life. In my experience, I often speak with patients about what I call the 5 medicines and what is my approach to addressing nociplastic pain. And the 5 medicines for me is 1, mind is medicine. And by mind, I mean knowledge. And I want to make sure my patients are knowledgeable. 2, psychology is medicine. And by this, I mean the patient's mindset and the personal narrative they tell themselves about their pain and their story. 3, sleep is medicine, and good sleep is absolutely essential. 4, movement is medicine, and we want to make sure that patients aren't afraid of moving or have kinesiophobia. And 5, finally, medicine is medicine. And when I get patients with nociceptive pain educated and knowledgeable about the correct treatment, I find that I can often make positive changes that result in improved pain management, function, and life for the patient. For medical management, I often work on applying evidence-based treatments. In this case, I would suggest to Edward either gradually tapering off his opioids in a very controlled fashion, as well as a rotation to other agents such as duloxetine. So let's summarize with some clinical pearls. 1, nociplastic pain is an important type of pain to consider. 2, nociplastic pain is a clinical diagnosis, although the central sensitization inventory can be helpful and is a validated adjunct to making the diagnosis. 3, nociplastic pain, nociceptive pain, and neuropathic pain can all coexist in the same patient. So sometimes you see patients with mixed pain types. 4, nociplastic pain is often worsened by opioid therapy, and opioids are medications of last resort. And 5, the evidence-based treatment of nociplastic pain involves excellent non-pharmacologic management, education of the patient, and if pharmacology is pursued, typically psychotropic medications such as tricyclic antidepressants or duloxetine have the greatest evidence of benefit. Thank you for tuning in.
This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's Compass Opiate Stewardship in Practice. Thank you for being part of the Compass Opiate Stewardship Program, and thank you for all you do caring for your patients. See you next time.